Welcome to Ask the Mayo Mom, and thank you for joining us today on Mayo Clinic's Facebook Live. I'm Dr. Angela Mattke, a pediatrician and mom at the Mayo Clinic Children's Center in Rochester, Minnesota. Each month, I host a Facebook Live interactive show about pediatric health topics. Today, we're discussing pediatric orthopedics and with a focus on sports-related injuries, as well as new treatments for scoliosis. Each year in the United States, between 20 and 30 million children between the ages of 6 and 17 years of age are playing team sports. There are many benefits for youth sports participation. Youth that participate are more likely to maintain a healthy weight, have better self-esteem and body image, gain social competency skills, and have higher academic achievement. Also, youth that participate in sports are less likely to get into trouble with the law. They have lower rates of teenage pregnancies and are less likely to drop out of high school. However, participation in sports, especially certain sports, places them at higher risk of injury. Dr. Todd Milbrandt is here today as my guest to help us learn and talk more about sports-related injuries and scoliosis. Dr. Milbrandt is a pediatric and orthopedic surgeon at the Mayo Clinic Children's Center. He's also an avid outdoor and sports enthusiast, and you can follow him on Twitter at Todd Milbrandt, MD. Please send your questions under the Mayo Clinic's Facebook Live feed. However, each child is unique and we cannot offer specific medical guidance for your child. So, Dr. Milbrandt, thank you for joining us here today.
No problem. Thanks for the invitation.
This will be good. I think there's going to hopefully have a good discussion today and maybe some great questions that'll come in from our audience.
No problem.
So, why did you choose to specialize in pediatric sports-related injuries for your children?
Well, a long time ago, and perhaps a few hair follicles ago, I was an athlete as a child, and I got so much out of it. And when I was going through and learning about orthopedic surgery, I was drawn to taking care of kids in general. Sports is one small subsection of pediatric orthopedics that I think has a large impact in the United States. And as I think about it now, so much of our children's lives, they aren't really given a job anymore. They don't, for the most part, don't have to work on the farm. Right. They aren't bringing in a large amount of money to help support the family. They have two jobs. One is to go to school, and the other is really to participate in sports. And so when they get injured, whether in sport or out of sport, the first question I get from them is, when can I go back? When can I play? Right. Now, that might be directed by them, and we can talk about that, but it might also be directed by their parents. Right. But youth sports participation, even across the board, is much higher now than it was even when I was a kid. And a lot of that has to do with the fact that both males and females are playing almost equally. And as a consequence of that, there are more opportunities for those kids to get injured.
Absolutely. I see a lot of, the more general sports injuries in my office, and you tend to see the higher end of injuries, the ones that maybe require surgery and whatnot. Which sports maybe place student athletes at higher risk of injury? Well,
I think that we need to make the difference between injury from an orthopedic standpoint and injury in general. The ones that has made the news recently are concussions, right? And I think that there are lots of sports that have a higher rate of concussion. Those that have contact have more higher rate of concussion. So football, lacrosse, even things like soccer where they head the ball have a high rate of concussion. I think that it's great that we're focusing a lot of our energies and interest in that because we don't know what the long-term consequence of these kids getting concussions. From an orthopedic standpoint, specifically the ACL, which is a ligament inside your knee, which we used to just think would happen to adults, are now happening in kids. And so much of that is because they're playing at a higher level, they're playing faster, they're playing with bigger kids, and they put themselves at risk. And so pivoting and twisting sports, things like basketball and soccer, really put the knee at risk when it comes to those things. Hockey, we get a mix of, here in Minnesota, a mix between lots of different things. Concussions, one, but also upper and lower extremity fractures tend to be more common in the hockey players.
Okay. Thanks. So you touched a little bit on ACL. Can you explain to us what the ACL is and a little bit more about what happens when the ACL is injured?
Yeah, so when I talk to families about it, it's really funny is the ACL is the most famous ligament that everybody knows, right? And most of it is because they heard that their favorite football player or basketball player tore that ligament. But there are lots and lots of people who tear this ligament playing sports, but also not playing sports. It is a ligament that lives inside your knee, and it prevents the movement of the shin bone from the femur bone. So if you don't have an ACL and you pivot, what will happen is your knee will actually feel like it's coming out of joint. And so it's what we call instability, and it can create instability. There are older people, maybe me, who, if you tear your ACL and you just plan on doing straight line activities, that you don't need to have it reconstructed, because we're not really doing things at that level, but that would put your knee at risk. But kids, we used to just treat them non-operatively. We'd never replace an ACL in a child. And a lot of that was because of the growth plates that are on the femur and on the tibia would be hurt if we were to reconstruct that. So we used to just kind of pawn them off until they were adult, and then we would reconstruct their knee. And by doing that, we've learned most recently, there's a great review out that said if you delay that, then the other parts of the knee start to fall apart because their knee is twisting all the time. That then tears their meniscus and puts their cartilage at risk. And so we've become much more aggressive, I would say, in the last 8 to 10 years of reconstructing these joints and coming up with creative ways to dance around the growth plate. Because without that, then you might hurt growth as you reconstruct it.
Okay. So can you describe the reconstructive surgery to us? Is it an open surgery? Is it something you do laparoscopically?
Yeah. So we don't do it open unless the child is very young. Our youngest child we've taken care of is 8. And so we had an 8-year-old that had an ACL tear. And that is becoming, unfortunately, more common. We used to never see that, but we do see it. So if they're 8, there is really no way for you to do this surgery in the traditional way, which is the traditional way is using an arthroscope inside the knee and by drilling holes through the bone that don't violate the growth plates or do at the certain time when the growth is about to be done. Then we use a ligament, most likely their own ligament. So we use a hamstring from them, and that ligament then becomes the replacement of their ACL.
What does the recovery process look like for an athlete after they've undergone a reconstructive ACL repair at a young age?
Yeah, it's the same. It's amazing. The kids usually recover much quicker. They whine a lot less than the adults do. But you have to find that therapist that can talk to them. So much of ACL rehabilitation is finding the connection between child and therapist, and that can be challenging on either end. And so if they do that, then you're looking at, in reality, they can walk right afterwards. We have them first work on range of motion really for the first 4 to 6 weeks, and then after that, then they start working on strengthening that leg. Return to sport is really the biggest question, right?
Absolutely.
And so they all want to know, when can I go? When can I go? There are some groups that in adults allow them to return at 6 months. I find that highly risky to that ACL. In my book, it's anywhere between 9 and 12, and they have to. It's not just a time thing. They have to show me that their thigh muscle is strong and has regained its strength, because that's what, in the end, what ends up protecting that ligament that I put in there.
So a lot of the physical therapy is going to be directed at increasing the quadriceps muscles and hamstrings and stuff.
That's right. So they do specific exercises with their therapist and then on their own. Cycling is a big part of it. Wall sits, everything that you can possibly do. This thigh muscle ends up really becoming this wet piece of noodle. It really is not great right after surgery, and eventually it becomes strong again.
Okay, thanks. So if anybody has any other questions about ACL, please send in those questions. But let's move on to talking about another common injury that you see for surgical repair, and that is patellofemoral dislocation. Can you tell us what that is and how that happens?
Yeah, so patellofemoral dislocation is a fancy word for saying that your kneecap came out, right? And so this is seen very commonly. It's the number one injury knee injury in kids. And so what happens is, as the knee comes out, it tears a ligament on the inside of that kneecap, the one that attaches it to the femur bone. it will become famous. It's not as famous as the ACL, but it's
It's
called the
getting there.
It's good there. It's got its own Twitter page, but it's called the MPFL.
Yeah.
But yeah, I'm just kidding. There's no Twitter page for the MPFL.
But there's a Facebook page.
There's probably. But it's called the medial patellofemoral ligament.
Okay.
And we have learned recently, especially as I've moved to the Midwest and there's a lot more Scandinavian people here. The people in Finland are really the people who have driven this science long before the Americans did, and that was because their genetic makeup there seems to want to put the kneecap out of place. Now, whether or not that's a less deep groove for that or that they're long and tall, it is unclear. But here, even in the Midwest, it's a very common injury.
Okay.
And so we have to look at a couple different factors. It's not just this ligament that tears. We have to look to see if their knee is in a knock-knee position, if they have rotational problems. We look at how deep the groove is. So it's a relatively complicated workup, but most of the time we can just treat it with another ligament reconstruction, just like we did for the ACL.
Is surgery always going to be needed for the dislocation?
Yeah, that's a great question, and we are still trying to figure that one out.
Okay.
There is a higher rate of redislocation after the first time, but how much is too much?
Even after repair, there's a higher rate of dislocation, or just
so if you try and treat it without a surgery,
Gotcha.
There's a higher rate of redislocation. And the literature varies as to how much it is. Right now, if they don't have a chondral injury, meaning they don't have a cartilage problem at the time of dislocation, and it's their first time, my approach is to try and get their legs strong enough and not do surgery.
Okay.
But then once they prove to me that they've had a second dislocation, or if they've knocked off a piece of their cartilage, then at that point, then we start to talk about an operation.
Okay. Yeah. So tell me a little bit about if there's any different patterns that you may see between boys and girls in regards to injuries.
Yeah.
So one thing that I have heard over the years is girls are more prone to maybe more knee injuries, especially ACL.
Yeah.
But is that true?
Yeah, it totally is true.
Okay.
And we are still, there's been some good literature actually centered here from the clinic looking at why this might be. Some of it we think is hormonal based. So the ligaments become more loose as their cycles go.
Okay.
So that's one part of it. The second is that they've decided that the notch that is in between the two bones on the femur is skinnier. And so if you can imagine, if that knee twists a little bit, that ligament gets caught on that bone and could potentially tear. Okay. And as girls land, they have videotaped girls jumping off of heights, and they tend to land with their knees going in, and that puts that ligament at risk as well. And so to try and go after this, they've actually created a exercise program to try and teach girls and boys how to land with their knees straight. And a lot of it comes from, instead of using the quad as much, using the buttock muscle to try and absorb that shock. And so they've implemented that in a couple Division I college girls soccer programs, and they've decreased the rate of ACL tears in those programs. And so those exercises can be found online. The FIFA exercises are really the ones that I try and promote when they ask me, what can I do to try and prevent my child from having an ACL? Unfortunately, the girls to boys ratio in that is much higher. So girls basketball and soccer, like we talked about, those are the highest risk types of sports that the girls do.
Okay. What about other types of injuries? Are there certain steps or measures that parents and student athletes can take to prevent their injuries?
Well, I mean, I think that when we think of injuries, it's not just ligamentous, but it's bony related too. I think that the other things they can do from a bony standpoint is make sure that their vitamin D level is the right.
Okay.
We live in a place here in Minnesota where we live in the dark. We don't get a whole lot of sunshine for 4 to 5 months. And because of that, the vitamin D levels probably are not where they should be. We did a study where I worked previously, and 80% of the kids that walked in the orthopedic clinic, all comers, had a low to deficient vitamin D level. And so in my practice, I tend to really try and push kids to take vitamin D. Now, will that make a difference in the short term in terms of will they get a fraction next year? I don't know, but I do know that it will help them when they're 50 if their vitamin D and their bone stock is better. In terms of what they can do otherwise, we've seen a trend, just like we chatted about before, about subspecialization in sports. And this is something that I think has been going around a lot in the popular news media, and that you think that if your child is going to be the next Michael Jordan, that he needs to start playing basketball when he's 4. And that's the only way that he'll get on the travel team. It's the only way he'll get on the high school team. And so they end up playing basketball basically 12 months out of the year.
Right.
And that does not allow a child's body to recover from that stress. And so we've actually seen a higher rate of stress fractures, things we never saw in kids, because they don't ever either take a break or switch up their sport so that then they're using different muscles.
Groups, absolutely.
There was another interesting study where they looked at NFL players and they asked them what they did in high school. And so many of those players were not football players primarily. They were football and basketball and baseball. They kind of mixed it up throughout the year. And so I think that it's really important, if you have a child that's very interested in sports, that they have either at least one season off a year and or they try and play different sports throughout the year, at least for half the year, to try and build different muscles so they don't get these stress fractures.
Absolutely. And there's so many other things that go into the overtraining too. Sometimes overtraining, actually you're seeing decreasing yield and returns in your performance because they're not getting that recovery time in. There's also the psychological aspect, the burnout that can be associated with it, the pressures, the anxiety that can be related with performance and stuff, and we're seeing it in younger and younger children.
I totally agree.
Yeah.
But I feel for the kids and for the families, because even my own kids, they know their friends on the sporting team more than they know their neighbors. And I think that it's a little bit of our modern society, in that when they call up their buddies, they call up their buddies from their traveling soccer team instead of the neighborhood kids. And it's a switch. And so that even puts more pressure on, if they get injured, then it takes them out of that peer group and they don't get to see their friends as much as they did before.
Absolutely. So take-home message is, let your children be children,
right.
and have some downtime, and make sure that they're not constantly practicing on one sport, that they're doing other things, not only sports, but also other enrichments with their brain, their mind, downtime, those kind of things.
Rest is an underemphasized part of sport. You really don't recover well, and they need rest from a brain standpoint, but also from a muscle standpoint.
Great. So we have another question, or we have a question that's come in, and I think this is a good place to take it because it doesn't quite fit in with what we've been talking about with the sports injuries. But this one is about severe flat feet in a teen. Is this something that you would intervene on for surgical intervention? And if you would, what would be the timing of that?
Yeah, so flat feet are things that we see in the orthopedic clinic all the time. If you kind of surveyed throughout the United States, there are tons and tons of adults who have flat feet that are asymptomatic. And so our first rule of thumb is we don't do anything. Just because you have flat feet doesn't mean that they have to be corrected. Not everybody's feet are the same. Just like, I have a little less hair than you do. That's just the way that it goes, right? However, if the switching point is when those flat feet become painful for them. And we try lots of other things. Most of it is a shoe performance. So they're trying to fit their very flat, wide foot into a very narrow shoe, or they're trying to recreate an arch by making an arch in the shoe. And when they do that, then the child tries to walk on this big arch, which their foot is not made to do, and they are uncomfortable.
Absolutely.
We do use orthotics at times when the shoe modification doesn't work. The orthotics create a nice, gentle, small amount of arch support in a soft way, and that helps some kids. But then now you're talking percentage-wise, we're down to now maybe the 5 to 10% of the kids that we see with flat feet who have failed all of those other interventions.
Right.
Then we start talking about surgery. The surgery itself is something where we try and do an operation on the outside of the foot to drive the flat foot around, and it creates an arch. Okay. It's one of those things that is not very common, and we don't really recommend it at first go. We try a lot of different things because while that operation corrects the flat foot part, it does make the foot a little bit stiffer. And so they want a foot that might look different, but it might act worse after our operation. So it's a balancing act for sure.
Thanks.
Yeah.
Let's move on to talking about another bone issue. So this one is scoliosis.
All right.
What is scoliosis? Help us understand that so we can kind of lay the groundwork for the treatments.
Yeah. So scoliosis is an inherited genetic disease. It's disease. It sounds like you caught it, but you didn't. You caught it from your parents, I guess. But the bottom line is that it creates a curvature of your spine, and it is very highly related into families. So we'll find not only did mom have it or grandma, but cousins sometimes have it. For the most part, it used to be that you would be screened for it in your 5th, 6th, and 7th grades, but those screening systems have really gone away. And we're actually working on some paper, much unfortunately to the detriment of treatment of scoliosis. We see scoliosis now that's showing up worse, things that could have been braced that we've missed because of those screening systems have been taken away. But the bottom line is it usually shows up in the typical way in a teenage girl who is just about to start their growing spurt. And that's anywhere between 10 and 14 in girls, or maybe even 9 and 14 in girls. It is directly related to growth. So as they are becoming more mature, their height is increasing, then their scoliosis can happen. And so we'll see sometimes mom will say, look, I saw her in a swimsuit last summer and she was fine. Suddenly she puts on the swimsuit this next upcoming summer and she has a large curve. And it's because during that winter time she grew.
Yeah, absolutely.
And so what is it exactly? It's a deviation of the spine. It's a curvature of the spine. If you have a small curve, it really doesn't mean much. So if you're a skeletally mature adult and you have a 30-degree curve, you will have the same back pain as anybody else. However, if you end up having a larger curve, especially in a growing child, that child could potentially have that curve worsen as their life goes on. And then that might lead to further and further deformity and potentially, if the curve gets large enough, cardiovascular problems. But we used to say that you have to have your scoliosis fixed because it's going to save your heart and your lungs. It's probably not true unless that curve gets massive, 100, 115 degrees, something like that. But it is relatively, it does change your appearance significantly if you have a curve that throws one shoulder higher or pushes you to the side compared to where your pelvis is. And so it is something that we address with the kids that way. So it is not, unfortunately, it's not anything that the families can do anything about. They can't exercise their way out of this. They can't eat their way out of this. There's no special medicine that I can give them that makes this better. There are some small groups that have tried to address small curves with specific physical therapy. It's called the Schroth method, and it's becoming more popular in small curves in kids who are motivated to do 2 to 3 hours of exercise to try and mold their back. We're just kind of learning that it's been popular in Europe and starting to come around here in the United States. But again, if you have a larger curve, you can't really beat that with your muscles.
What do you guys use for treatments as the curves start to get progressively higher and higher, and how do you classify the types of curves? We
usually typically create we classify them based on an angle measurement. So we take the most tilted one at the top and we look at the most tilted one at the bottom and we give it a Cobb measurement. And that is the measurement that many people will hear when their doctor talks to them about scoliosis. Under less than 20 degrees is typically what we would consider mild. Anything between 20 and 40 is considered moderate. And then above 50 degrees is when we start to talk about surgery. Because it's in that moderate group that in a growing child that bracing really might work. And unfortunately with the loss of the screening systems, they're showing up to us with a larger curve, and we've lost the opportunity to brace them and potentially avoid an operation, because that's our whole point with the brace. And so bracing is, everybody's heard or seen a scoliosis brace. It isn't pleasant, but it is effective. If worn with the right amount of hours a day in the right growing child, then it can prevent a surgery about 75% of the time, which which is, between that and a scoliosis fusion, which is a very large operation, is a big save in our mind.
Absolutely. Let's talk about that surgery you just mentioned. So, the classic surgery has been the fusion.
That's right.
But Mayo has been working to develop a new technique that's being used in other places as well.
That's right.
Can you talk about those two different techniques? And
Yeah.
I think we have some assistance with some x-rays as well.
Yeah, so what we'll show you now is a image of a child before an operation and then after an operation. And you can see on the right image, the patient has 2 rods and screws that go throughout the spinal into the spinal bones called the vertebra. So those screws are called pedicle screws, and they're connected by a spinal rod. We hope that between the top and the bottom there, that the bone fuses all of those segments together. And by doing that, it prevents scoliosis from progressing through time. And that's the whole goal of this operation, is really to prevent progression through time. The downside of this operation, well, the upside is it's a one and done operation. It is in a healthy teenage person, a very safe and predictable operation. We have the neurologic risk is probably 0.1%, so it's an incredibly safe operation. But the downside is that it's a fusion operation. So we've taken all these vertebral levels that in you and I move, and they don't move. And anytime you do that in the body, you tend to wear out the stuff at the top and you wear out the stuff at the bottom because this child has another 60 years to live, and that's a lot of movement to put stress on the bottom vertebral bodies. So we have we've started to explore a different type of operation in a very small specific subset of patients that might be able to allow those vertebral bodies to continue to move throughout the life, throughout their life. We are not the first people to do this. There is a large group in other centers that have kind of showed us the major technique. We are refining it here at the clinic. And here you can show the next x-ray. This is what we call a vertebral body stapling or vertebral body tethering operation. And what you can see are the screws are placed from the side through a scope in the chest, and then in reality a nylon string is what connects all of those screws together. And you can see that the scoliosis is corrected, and those vertebral bodies will continue to move throughout this person's life. The people that can qualify for this surgery are young people, and so this is a person who is at the beginning of their growth and has a curve somewhere between 40 and 60. So inevitably they would have an operation, a fusion operation, if we let it go long enough. But these kids, our hope is that if you slow the growth down on the one side, that through growth, they'll actually grow out of the curve. So that means that the curve will continue to grow on the other side where the screws are not, and will slow where the screws are. And so it takes that right-hand turn, and our hope is that it turns it into a straight spine. The benefit of that is clearly that we could maintain motion. That's what we're the most excited about. We can get the spine straight with our traditional ways, and we're happy with our results. However, we're not happy with the fact that we have to take movable spinal bones and make them immovable anymore.
Absolutely. You said that this is ideally earlier in the growth process, especially for a young female, and we often will use to determine whether they've had their first menstrual period yet or after their first menstrual period.
That's right.
Where does it fit along from that standpoint? Is it usually going to be like pre or post-menarchal?
Usually it's pre.
Okay.
I mean, the ideal person is someone who is premenarchal, who has lots of growing left, and has a pretty big curve already. So these are usually people who really either can't stand the brace or for whatever reason can't deal with the brace, or now we've progressed to the point of being a 40 to 60 degree curve even in the brace, which sometimes happens. And so I think that this is something that we're learning about. We're really just doing it also in curves that are in the chest, so that one right thoracic curve. What happens when you have a curve down in your lumbar spine? We're still trying to figure some of these details out.
Okay, well, stay tuned then
Yeah.
for the coming years for new research and new possibilities to treat scoliosis. This is really exciting. I know we've had some success and some patient stories that have been featured. So if you're one of those patients, or you can contact Mayo Clinic and see if you're a good candidate for this surgery. So
For sure.
absolutely. Well, this is all the time we have for today. I want to say thank you to everyone for joining me, and thank you for joining us today.
No problem.
And next month, on February 2nd, we'll be having Dr. Timothy Nelson coming in to talk about hypoplastic left heart syndrome and some of the new potential treatments and studies that we're doing here at Mayo Clinic with stem cells to help regenerate parts of the heart. So please join us at 10 o'clock on February 2nd, and thanks everyone for engaging with us today and watching.
Thanks a lot.